Ma'am, the webinar is online.
Yes. Good evening to all. I welcome you all for the TNFOG Marathon CME. Why this Marathon CME is called means, during this CME, we have one theme. This month theme is contraception. Because September 26th is World Contraception Day, we have taken this theme as contraception. In this webinar, we have 3 sessions. First session being for UAs. The 2 UAs will be speaking, and we have the same judges. The judges will, at the end of the programs, that is at the end of the year, in the annual conference, for the best UA speaker, the award will be given. That oration award will be given. And the second session is for the guest lecture by seniors. And third session is by the panel on the same theme. So this is called, why it is called as Marathon CME. Today we have our chief guest as Dr. Sunita Tendulkar, who is the president-elect. Now I welcome our president, Dr. Revathi Janakiraman, for the welcome address. And I all welcome the delegates. Thank you. Dr. Revathi Janakiraman. Yes, Adhika, you can introduce.
Yes, ma'am. Good evening, respected madams and sir. Professor Madam Dr. Revathi Janakiraman ma'am needs no introduction, but she is the former director IOG Chennai.
Just a few lines is enough.
Okay, ma'am. Vice President Foxy South Zone 2016, and she is the President TNFOG in 2023.
Okay, thank you.
Thank you.
Good evening, all. It's my great pleasure to welcome you all to this interesting webinar on contraception. As Dr. Sampath Kumari said, 26 September is the World Contraception Day. And it's my great pleasure to welcome our chief guest, Dr. Sunita Tendulkar, my best friend, and our president-elect Foxy. And I also welcome all the faculties and the delegates to this interesting webinar. And you know, the World Contraception Day is dedicated to raising awareness about the use of contraception and other population control measures. This day also advocates the rights of the women to choose the number, timing, and spacing of the children. The theme of this year's World Contraception Day is the power of options. It shows light on the crucial role that contraceptive choices play in empowering the individuals to take control of their reproductive health. That is very, very important. This worldwide campaign is mainly vision is that every pregnancy in the world should be only wanted pregnancy. Based on that only, this year work is going on, and I'm sure the topics chosen today and the speakers are also well versed, and they are going to throw light on this aspect. And definitely all delegates will have a lot of carry home messages and clear their doubts also. Once again, I welcome you all to this webinar. Thank you very much.
Thank you, madam. So, the next is the Tamil Thai வாழ்த்து. We welcome everybody to this session, and the next part of the program is the Kuttuvilakku lighting. by our President-elect.
Revati madam, you can introduce the chief
Yeah.
guest, madam.
Now it's my great pleasure to introduce Dr. Sunita Tandulkar. And of course, she doesn't require any introduction. Her academic excellence, we are all seeing through various WhatsApp groups recently. And everyone was so much impressed. And that's why she got elected. Okay. And she's the head of the department, Chief IVF Endoscopy Center, Ruby Hall Clinic, Pune. Advisor and consultant, Dr. D.Y. Patel, IVF Endoscopy Center, Pune, and founder and medical director of Solo Clinic IVF. She's so much interested in the ART procedures and more than that, endoscopic surgery. And really her excellent endoscopic surgical techniques we witnessed in various conferences, really a wonderful thing. And she is also President POGS 2021 and 22, Chairperson, Founder, Honorary Secretary,
That's
MSR,
okay, ma'am.
Senior Vice President,
That's okay,
ISR.
ma'am.
So extraordinary
That's
achievement
okay.
is India's first stem cell baby and world's first at the age of 45 on 16th April 2018. Welcome, Dr. Sunita, to share your ideas.
First of all, thank you so much. It's complete TNFOG from my bottom of heart. I'm absolutely humbled to be here on this platform because this is the organization which gave me wholehearted support. I'm really thankful. And Sampath, you never said me, I'm sitting on a chair, I cannot do this, I cannot do that. You always extended your hand of friendship. And you always introduced me to your various societies, presidents, secretaries, members, Foxians. If you tell the name of all the society, they are on my tip of the tongue. So much I got connected with it. And Revati madam, as a TNFOG president, you always, whatever the ideas, whatever the program, Sampath wanted to do with me, you always wholeheartedly supported. And I'm so thankful to each and every one of you. It's honor to be on this platform. And I like the concept of taking one subject and taking ahead. But I realize that you are not only taking one subject and taking ahead, how in Foxy we have a young talent hunt. The same way is you are doing a one session completely, the presentation by the youngsters, and then probably monthly you are doing this, so that all month you will have the youngsters coming together, the best winner you will support. I definitely feel when at the young age, you get promoted by the organization that, that resident or whatever, that young gynecologist, she feels so elated. And that's our job as a senior, to help our juniors to feel confident, climb up and be there. When I went through the program, it is so well chosen with the topics, with this. But one thing I must tell you, your judges who are there, though you have written them as a professor, Nidhi and Vijay Lakshmi, they look so young. They're so young, at such a young age, they have become a professors and they are judging. That's a power of India. India has a huge talent, and we all have in a young age group population with us. So your panel discussion will be board, and Dr. Vivek sir, you are giving a smile all the time silently, but the MTP Act will be wonderful to listen to you, and the panel discussion with all case scenarios. I think contraception has given the woman the empowerment to the woman. It is so MTP Act and contraception has really empowered the woman to take the decision of her own. And that's where India has given, where the Western country has stopped the MTP, where India has come out and given the empowerment to the woman to decide their own fate. So I think we should feel proud that we are Indian, and then we should feel proud that we are obstetrician, we are helping. So thank you so much for making me on this platform today, and it will be wonderful to be with you all.
Thank you, Dr. Sunita.
Thank
all
you,
the
Sudha,
best
for your
for
kind
your,
words.
Thank you.
Thank you. Thank you.
Thank you.
Radhika, now we
Thank
can
you,
go
ma'am.
with the scientific session.
Okay,
So we
ma'am.
are eagerly waiting for Dr. Sunita's tenure.
Yeah. And I am going to make you do one conference for me.
Sure,
You
definitely.
have to do. I missed your Andaman, you have to do Andaman. I missed your Kodaikanal, you have to do it Kodaikanal.
Sure,
I only came to Calicut, so no Kerala conference.
definitely. We will do it. We will
Yeah,
do a
you and
wonderful work.
Palani,
Mm,
you and
thank you.
Palani together.
Sure, sure. Definitely.
Thank you.
Thank you.
Thank you, ma'am.
Thank you.
Thank you, Sunita ma'am, Sampath ma'am, Revati ma'am. We'll move on to the next session where Dr. Nidhi Sharma, Madam, Professor of Obs and Gynae at Savita University, and she's done her MBBS MS from Banaras Hindu University. She's a FICOG member and Fellow of Assisted Reproductive Techniques, and she's also specialist in IVF and reproductive medicine. She's done PhD degree in Obs and Gynae from Savita University. So I request Dr. Nidhi Sharma ma'am and Dr. Vijayalakshmi Kandasamy ma'am to be the judges for this session. Dr. Vijayalakshmi ma'am is the professor of Chettinad Hospital and Research Institute, Kelambakam, Chennai, and she has won special prizes and achievements as a State Secretary Appreciation Award for exemplary performance. And she's now currently the IMA Velacheri branch president, chairperson in Women Doctors Wing, IMA Velacheri. And the two speakers are, the topic is the emergency contraceptive pills by Dr. Kirtana. Dr. Vijayalakshmi ma'am.
Yeah, good evening. Thank you for the introduction.
Thank you.
So now we have our first speaker. I suppose it will be Dr. Aarti speaking to us, because I see her CV. Is Dr. Kirtana also logged in?
Yes, ma'am.
Yes, you can introduce
yes.
Aarti. Whoever is logged,
Whoever
can
is
do it.
Yeah, Dr. Kirtana, who is an undergraduate from the PSG Institute of Medical Sciences and has done her degree of MSOG from KMC Manipal, Bangalore, and her postdoctoral fellowship from endogynecology at the MGR University. And she is the youth committee member of the Nagarkoil Obs and Gynae Society. And she's also won a Best Poster Award at ISAR 2020. Welcome, Dr. Kirtana. I suppose you'll be enlightening us on emergency contraception.
Yes, ma'am.
The stage is yours. Please go ahead.
Thank you, ma'am. Thank you for the introduction, ma'am. Is my screen visible, ma'am?
Yes, it's visible.
Make
Please
it full
put it
screen.
in full screen, please.
Yes, ma'am.
Dr. Kirtana, you have 12 minutes for presentation and 3 minutes by questions by the judges.
Yes, ma'am. Sure, ma'am.
Okay.
The topic given for me is emergency contraceptive pills. First, let's delve into the definition of emergency contraception. It refers to the methods of contraception that can be used to prevent pregnancy after sexual intercourse. Now, it is a safe means of preventing pregnancy following unprotected sexual intercourse or potential contraceptive failure. That is, it acts after intercourse and before the potential time of implantation. And we've got many colloquial terms for that, the postcoital contraception and the morning after pill. But the WHO advocated term is emergency contraception, and that's how we're going to go about the term. So now the main thing is, why is there an emergency contraception? Is it a plan B? That's why we have it as the drug, plan B, one-step drug. So it is a plan B. So why do we want a plan B on first place? Because plan B can cause people. Basically, there are accidents that can cause people. So that's why we are going for emergency contraception. So why is this emergency contraception important? Each year, approximately 85 million women, that is 41% of the world, face an unintended pregnancy. 46 million unwanted pregnancy end in abortion each year, 20 million of which are unsafe. More than 1 in 7 of these cases occur in India. According to the Indian statistics, we have the WHO Global Health Statistics from 2012 and the 2015 statistics, which states that the contraceptive prevalence in the country is 56%. This is after even all the contraceptives are available in the country. The rate of unintended pregnancy was estimated at 70 pregnancies per 1,000 women aged 15 to 49 years. It is estimated that 15.6 million abortions took place in 2015, giving an abortion rate of 47 per 1,000 women aged 15 to 49 years, that is a reproductive age group. So with the use of effective contraception, 90% of abortion-related and 20% of pregnancy-related morbidity and mortality can be prevented. So this is the response to the problem that we are looking for. And Indian statistics and Indian scenarios state that the emergency contraceptive pills are largely underutilized even after being made an over-the-counter drug. So basically, the effectiveness of EC pills, these are the important statistics. When among the 100 women, when they don't use an emergency contraceptive pills, it results in 8 pregnancies. Whereas the progesterone-only ECP is used, that is the levonorgestrel, which is widely available in India, is used. There is a chance of 1 pregnancy. Whereas the combined estrogen-progesterone emergency contraceptive, that is the USP regimen, is employed, then it results in 2 pregnancies. So these are the effectiveness of EC pills. And coming to India, in India, EC pills were introduced by the Ministry of Health and Family Welfare in 2002 and was made over-the-counter drug in 2005. But even after that, less than 1/3 of the women were aware of EC pills and less than 1% have used it. Now coming to the indications, when do we give emergency contraception? When no contraceptive has been used, when a sexual assault where the women was not protected by an effective contraceptive method, or when there is a concern of possible contraceptive failure from an improper or incorrect use, such as condom breakage, slippage, or incorrect use, 3 or more consecutively missed combined OC pills, or 3 days late during the first week of the cycle, more than 3 hours late from the usual time of intake of progesterone-only pill, or more than 27 hours after the previous pill. This means there's been a 24 hours gap plus 3 hours. That makes it 27 hours. And more than 12 hours late from the usual time of intake of desogestrel containing pill, or more than 36 hours after the previous pill. More than 2 weeks late for the norethistron enanthate progesterone only injection. More than 4 weeks late for depot medroxyprogesterone acetate progesterone only injection. And when there are other items like dislodgement, breakage, tearing, or early removal of diaphragm or cervical cap, when there is a failed withdrawal, example, ejaculation in the vagina or the external genitalia, or failure of a spermicide tablet or film to melt before intercourse. And when then the fertility awareness methods is a miscalculation of the abstinence period, or failure to abstain or use barrier method on the fertile days of the cycle, and expulsion of an IUD or hormonal contraceptive implant. And what are the types? There are 2 types, the hormonal and the mechanical. The topic being EC pills, will stick more to the hormonal side. The mechanical being copper IUD, which is the most effective till date. But with deficient studies on that aspect, we'll focus on the hormonal type. Now, the main considerations are timing of presentation. So when does she present to the doctor? After her last unprotected sexual intercourse. Then the patient factors, the drugs she is taking, the obesity, and the availability of the contraception in that particular location, country, or state. So now the timing of presentation is important because most methods are effective only within 72 hours. For example, our LNG, our USP regimen all works well and with good efficacy within 72 hours. Whereas the ulipristal acetate, mifepristone, and copper IUD works within 120 hours, that is 5 days. And the Persian factor, as mentioned, the obesity. Higher the BMI is not a contraindication, but has been proven that levonorgestrel has decreased action in a patient with BMI of more than 30. And levonorgestrel is metabolized by a cytochrome enzyme. So again, the drugs that induces the enzyme, that is the antifungals and the antiepileptics, will decrease the efficacy of LNG. So an alternate method should be given to these patients who are on these drugs of antifungals and antiepileptics. Now coming to the USP method, which is a combined one, where we use both estrogen and progesterone for emergency contraception. This is the oldest form. We give 2 doses, each dose containing 100 microgram ethinyl estradiol and 1 milligram norgestrel or 0.5 milligram levonorgestrel 12 hours apart. This acts by delaying or inhibiting the ovulation when utilized during the first half of the menstrual cycle. It works only if the follicles are not well developed. And the failure rate is about 2 of the women who have used correctly. So which gives 1.9%. And most patients complain of nausea and vomiting, and antiemetics have been documented to be given before this USP method. And there have been no changes or menstrual bleeding, mastalgia, and increased risk of thromboembolism has also been observed. Now coming to levonorgestrel, this is what is widely available all over India, recommended by the government. The progesterone only pill, it is a single dose of 1.5 mg. So that's why it's called the one step. The plan B one-step drug is levonorgestrel 1.5 mg or 2 doses of 0.75 mg 12 hours apart. Basically, it acts by suppressing the LH, which delays or inhibits the ovulation. Again, it has to be given before the LH surge occurs. So that's when this drug is administered closer to the time of ovulation, or if the LH surge had happened, it is proven to be less effective. So now there is this WHO randomized control trial in 1998, which compared both USP and levonorgestrel. And levonorgestrel has proven to be a better drug in preventing the pregnancy with the efficacy rate within 24 hours of 85%. But again, this study also showed that the efficacy of levonorgestrel decreased with time. That is, when given within 24 hours of unprotected sexual intercourse, it's 95%, and it comes down to 58% later than that. Again, the efficacy, this has to be addressed because the obese patient, that is the ones who are more than 70 kg or with BMI of more than 26, have got a 4-fold risk in being the LNG failure compared with the women with normal BMI. But again, the dose has to be doubled in these cases, like 3 mg has to be given. But again, this was not well documented, and we don't have enough studies to support this hypothesis or this finding that we are noting in the clinical settings. And the nausea is 23% and vomiting is 5.6%, which is a better profile compared to the USP method. And there is a disruption of the menstrual pattern because we are giving it in the pre-ovulatory phase of the cycle. So the menstrual cycle might get abbreviated. Now coming to mifepristone. This is not given in India. It is an anti-progestin. It is used in China. We use that the low dose has to be as low as 10 mg, and it can be given within 5 days. Mainly, it acts in the follicular phase. It delays the estrogen rise, LH surge, and ovulation, and leads to inhibition of ovulation. Even if the ovulation has happened, it inhibits endometrial development and prevents implantation. The main mechanism of it in the emergency contraception is the pre-implantation. But again, in India, we use it as an abortifacient with higher doses. But this was the efficacy of emergency contraceptive was found better to be at 10 mg with a better side effect profile and no significant effect on obese women. Currently, it is used in Armenia, China, Russia, and Vietnam, and we don't have we don't find it in the available dose in India. And now coming to the wonder drug, the ulipristal acetate. It's a derivative of 19-norprogesterone. It's a selective progesterone receptor modulator. It is available as a 30 mg tablet single dose, and it can be given within 120 hours. That is 5 days after an unprotected sexual intercourse. It has been approved in many countries. In India from 2020 and from Europe from 2009. FDA has approved it in 2010 and Australia from 2016. So the mechanism of UPA has been, ulipristal acetate has been studied in all aspects. It has an inhibitory effect on ovulation, and it acts in the follicular phase. An important point is at the level of 14 to 16, when the lead follicle grows, it stops the lead follicle growth and it's replaced by a new lead follicle. Whereas in cases where the lead follicle is more than 18 mm, it delays the rupture by 5 to 6 days. By then, the sperms that are already in the female genital tract will become non-viable. So that's how it delays, and it's found to be effective. If vomiting occurs within 3 hours of taking the drug, the patients are requested to take another tablet. And the drug interactions are quite huge for this drug. The effectiveness of effectiveness of ulipristal acetate is reduced when the patient is already taking barbiturates, carbamazepine, phenytoin, greaseprevir, and rifampicin. Again, alterations in the gastric pH also reduce the absorption. So it's better to avoid the proton pump inhibitors, pantoprazole, omeprazole, rabeprazole, antacids, and the H2 blockers like ranitidine. And again, there are cytochrome enzyme inhibitors. So when antifungals are given along with the drug, the plasma concentrations are increased. So it's a strong drug interactor, and the history of the patient is very mandatory before prescribing the ulipristal acetate. And the main side effects are headache, nausea, abdominal pain, fatigue, dizziness, delayed periods by 2 days. No teratogenic or birth defects are noted, or no adverse effects following breastfeeding. So now ulipristal acetate and levonorgestrel have been compared. In that, ulipristal acetate is 2.5 times more effective, and it's effective regardless of the women's BMI. And FSRH, which is the highest sexual reproductive health functioning in the Europe, recommends ulipristal acetate as a first-line drug for emergency contraception. And this is the only drug which works up to the point of ovulation. That is by delaying the rupture of the lead follicle by 5 to 6 days. So now coming to the WHO recommendations, UPA taken as a single dose of 30, which is the first line that's been used in Europe and found to be very effective. And other with levonorgestrel taken as a single dose 1.5 milligram, or alternatively taken in 2 doses of 0.75 milligram 12 hours apart, used extensively in India. And the last one is the combined OCPs. That is our USP method. 100 microgram of ethinyl estradiol plus 0.5 milligram of levonorgestrel taken 12 hours apart. So these are the regimens recommended. And obviously, WHO also recommends a copper T. And to conclude, it's always EC is just a backup plan. It is not a routine contraceptive method. Even the patient with EC who comes, the routine contraceptive has to be explained. The pros and cons have to be employed. The age of the patient has to be taken into consideration. EC is just a backup plan. It's just a plan B. It can never be a plan A. So since it's a backup plan, it's always good to have a backup plan. And the words from WHO, an advanced supply of ECPs may be given to women to ensure that she will have them available when needed and can take as soon as possible after unprotected intercourse. This is given mainly for the safety of the women in the reproductive age group 15 to 49, to make it easily accessible to all the women in the age group of 15 to 49. And again, the main points are the patient preference, the provider's capability, and the local availability of the drug in the market is very important. So thank you, ma'am. Thank you for giving me this opportunity.
Thank you, Kirtana. That was a nice presentation.
Thank you.
Dr. Nidhi, are you there? As you said, supposing the woman has had a contact at the peri-ovulatory phase, peri-ovulatory, because most of these drugs, the EC, work just before the point of ovulation. Yes. So in the peri-ovulatory phase, which actually, according to you, will be the best method of emergency contraception for her?
Ma'am, regardless of the country, ma'am, I would go for ulipristal.
No, I'm talking about India, okay? The Indian scenario, yes.
Ulipristal acetate would be good, ma'am. But based on the availability, I think levonorgestrel is a better option because it's widely available and it's cheaper compared with ulipristal acetate.
Yes. And also our age-old
USP method.
Yes, IUCD or the USP method. As you said, the only side effect, what are the main side effect profile that you would come across with the USP?
Nausea and vomiting are the commonest side effects. Yeah.
So supposing she were to vomit out when she is starting with the USP regime, what will be the best backup? So as to speak about the plan C. And the woman is very keen on avoiding a pregnancy.
She has to use the barrier contraception for the next 14 days. And better is the abstinence.
No, we are talking about the act of coitus has happened and she has had a side effect to the USP regime. So I think you should probably think a little out of the box to tell me what will be the best plan C for her. You yourself gave a description about it in your presentation.
Up to 5 days.
Up to 5 days, you have said that, isn't it? Madam is giving you hints, Dr.
Yes.
Revati, madam.
Ulipristal acetate. Yes, ma'am.
You should advise her to go in for the IUCD. So we
Okay,
have
ma'am.
done that. We have done that in many patients. Yeah.
Okay, ma'am.
Thank you, Dr. Kirtana.
Thank you, ma'am. Thank you so much, ma'am.
Nidhi, Dr. Nidhi Sharma has not joined, I think. She told that she will join.
Sure, madam. She
If
hasn't
at all
joined, I
anyone-
suppose.
Hmm.
Yeah. So we'll go ahead with the next speaker. Yeah. Dr. Aarti will be our next speaker, who's an assistant professor at CMC Vellore and who has done her UG from Trivandrum, Kerala, and her MSOG from CMC Vellore. And she has several publications in national and international journals. And she's won the St. Mary George Medal for Best Outgoing Student at her college during her MS. And her special interests are minimally invasive gynecology. So, Dr. Aarti, over to you for your talk on the point of contention. As we all know, we obstetricians find it very difficult, the male contraception, from the age-old condom up to the recent updates. The stage is yours, Dr. Aarti.
Ma'am, we can't hear you, ma'am.
Dr. Aarti, the stage is yours. Am I audible?
Yes, ma'am. Vijayalakshmi, ma'am, I can hear you. Aarti, ma'am, voice is not audible.
Yeah, but I don't think we are seeing her screen as well.
Yes, ma'am, but ma'am is not audible. She's trying to connect the headphones, I guess.
Okay.
Ma'am, can you remove the headphones and try, ma'am? No, ma'am.
Has Dr. Aarti joined?
Yes, ma'am.
Shachikala?
Yes, ma'am. Yes, ma'am.
Yeah.
Where is Aarti?
Aarti, ma'am is here, ma'am.
She is
Aarti,
trying
ma'am,
it.
can you hear us? You can hear us. Just do a thumbs up. Okay, so in the mic, there is a mic icon. There is a small up arrow. If you click that, just ensure the microphone and speaker are same as system. It is same as system. Okay. Then there might be some problem in your speaker.
Audible now?
Yes, ma'am. Yes,
Yes,
ma'am.
Aarti.
Yeah. Please
I'll share.
Please share your screen, Dr. Aarti. Yeah.
Yes.
Ma'am, is my presentation seen?
Yes, ma'am. Can you please
Yes.
make it full screen? Yes, ma'am.
Good evening to all. Thank you, ma'am, for the introduction and the warm welcome. And thank you. I take this opportunity to thank all the TNFOG organizers for giving me this opportunity to present on male contraception from condoms to recent updates. So let's go into the topic. So over the past decades, we all know that the primary responsibility for the decision of family planning making or contraception is taken by women, and the men play a secondary role by supporting them in taking the decision. So around the world, nowadays, the study shows that both men and women, they are accepting the new methodologies in the contraception as well as in the new male hormonal contraceptives, which is coming into the market. So when you look at the world statistics, the male sterilization, the people who choose male sterilization are very minimal in number, 2.6. Men are motivated by desire to share the family. Sorry, I'm so sorry.
Please go ahead, Aarti. Your slides are not moving.
Myself, I'm not able to see properly. 1 second, ma'am. Give me 1 second.
Yeah. Actually, you're on a time limit here. Please.
12 minutes.
Yes, ma'am.
Yeah.
So, coming to the scenario in India, we have people have high level of knowledge among eligible couples, but still female sterilization remains the most widely used family planning method in spite of efforts to popularize the male sterilization. So when you look at the National Family Health Survey, fourth and fifth survey, still the male sterilization was found to be people was using less, the percentage who used the male sterilization was less in number. So why do we need a male contraception? So it is mainly for more recognition for the need of shared contraceptive responsibility and to reduce the burden traditionally placed almost exclusively on the female partner, and especially in cases where female cannot adapt for contraception due to medical or surgical problems. So in this survey number 5 also, the awareness of male men and women over the male sterilization is about 84%. So what are the methods available for male contraception? One, spacing methods are available and terminal methods are also available. So natural methods, barrier methods, and new upcoming hormonal methods, intravas devices come under spacing methods. And in terminal methods or permanent method, vasectomy and vas occlusion methods are there. So natural methods are nothing but abstinence, coitus interruptus, which is withdrawal of penis from the vagina before the ejaculation. The advantages being immediate availability and no cost, but the disadvantage is high failure rate. With typical use, it is 22 per 100 women years. And so it can be used only for educated and responsible couples. Condoms are most widely used barrier method made of latex. Non-latex methods are also available, like polyurethane or synthetic elastomers, which is thin, odorless, transparent, and which helps in transmitting the body heat. The advantages being widely available. Government has a free supply in the name Niro, and it protects against sexually transmitted infections, and it's helpful in non-compliance with other methods like pills, IUCD. And disadvantages being the slippage or breakage, which comes to around 3%. Failure rate is high, 18 per 100 women, latex allergy, and reduced sexual pleasure. Coming to the hormonal methods, these are all under preclinical trials now. So let's just look into the how it acts. So when we give a supraphysiological dosage of testosterone, it reduces the function, it affects the hypothalamus. So GnRH production is reduced. Thus, FSH and LH is reduced, which affects the testosterone production and also spermatogenesis by the Sertoli cells. So they are targeted hormonal and non-hormonal pills are there. So hormonal pills inhibit the production of sperm, and non-hormonal, they target the various organs, testis, epididymis, and also the sperm motility. So they are available as oral formulations, injectables, implants, and also transdermal gels and patches. So after a wide variety of study in India, WHO has conducted a multicentric study in between 1986 to 1990. And in that study, they have given testosterone enanthanate in the dosage 200 milligram weekly as IM injection, single contraceptive method. And they found that around 65 to 70% of men achieved azoospermia. They were safe and reversible contraception for at least 12 months. And the disadvantages being frequent weekly injections, presence of acne, weight gain, decrease in testicular volume, decrease in HDL, and increase in hemoglobin. So further, they came with the long-acting testosterone undecanoate, which is given monthly as 500 milligram injection, and they found to be effective. The efficacy was around 97%. It was safe and highly acceptable. Disadvantages being pain at the injection site, acne, weight gain, and same as testosterone enanthanate. So next, they have tried testosterone with various progestins like levonorgestrel, etonogestrel, norethistérone, and also DMPA. So progestin was found to enhance the inhibition of gonadotrophin secretion, leading to improved sperm suppression. So this was found to be effective. So finally, in overall in the studies, they found that testosterone only formulations were more effective in Asian men, and the combination pill were effective for all men all over the country, all over the world, and effectivity varies with population and also formulations. They've tried testosterone pellets also, which is an alternate route of delivery. It causes a steady testosterone concentration. It has to be used once in 3 to 6 months, changed 3 to 6 months. And the combination with progesterones were more effective. Efficacy was 85%. And transdermal via patches or gels, they were using for hypogonadism, but was not found very effective because of the skin irritation. Many men withdrew from the study. Gel show more efficacy than the patches in the treatment of hypogonadism. Daily application is one of the disadvantage. So alternative androgens were tried, like MEN7, DMAU, dimethenprolone, and decanoate. They were all under trial. And various testicular targets which they tried was gossypol, which is a cotton seed derivative which causes azoospermia and severe oligospermia. But the disadvantage being irreversible anti-fertility, that is 20%, and also hypokalemia. So now this is not available in the market. Indinopyridines, adjuvin. Adjuvin is a male patch which is non-toxic lonidavine analog, which disrupts the cellular bridges between spermatids and Sertoli cells and also block maturation of sperm in the testis. Reversibility was found in 95% in 210 days after discontinuation. Disadvantages, nothing much was there because as it crosses the enterohepatic circulation. Other other particles which was used was JQ1 retinoic acid receptor antagonist, and against epidermal targets HE6 and CRISP1. These are the proteins which were found in epidermal epithelium. So the targets against these proteins are still under trial. CATSPR, which is a gene for calcium ion channel in various parts of body, including the sperm tail, they also are targeted to immobilize the sperms. In future, I'm sure we'll be able to see all these things. It's all under preclinical trial. So next is intravas devices. So these are devices which is fitting into the vas deferens to block the sperm to going into the ejaculatory duct. So I've quoted some. One is intravasal control valve. This is a T-shaped valve made of gold and stainless steel, and it's made a microsurgery to implant. Next is vaso-occlusive plugs, which is made of medical grade polyurethane and medical grade silicone rubber. Chemosterilization using toxic and non-toxic materials to inject and block the sperms. Intravasal threads were tried, and also vessel gel. Vessel gel is created by Parsimonious Foundation in USA. This is actually the research shows this is under the last part of the trial. So within 1 year, 2023 to 24, this is promised to come into the market. How does it work? So when you inject the vessel gel into the vas, it actually blocks the vas from sperm entering in, and it is a semi-permeable gel. So the sperm can't pass through this gel. So thus it works for the contraception. So this is another ADAM, which is another injectable hydrogel, which is under trial. Advantages being no congestive epididymitis, no spontaneous reversal. Disadvantages, mild pain and granulomas. So terminal methods, vasectomy. It needs a surgical procedure to resect or close the vas deferens. There are two methods, conventional and no scalpel vasectomy. Conventional, which is needing an incision, 2 incisions in the scrotum, and no scalpel, which is needing a puncture. Techniques where ligation, clips, thermal or cautery can be used, vas plugs, excision, irrigation or facial interposition can be done. So this is a pictorial representation of vasectomy. Advantages being no routine contraception needed, simple procedure, less invasive, more cost effective than tubal ligation. And disadvantages being difficult reversal, pain, swelling and vasovagal reaction, no protection against STI. Complications being operative minimal complications like hematoma and all, sperm granules, recanalization, autoimmune response, psychological response, and failure rate being 0.15 per 100 women years. So why is it better than conventional? So it takes less time, less infection, fast recovery, no incision, no stitch needed, less nervousness, and less tissue injury, bleeding, or hematoma. So coming to the last, vas occlusion methods, this is RISUG, which is reversible inhibition of sperm under guidance. It's undergoing trials now after working for almost 3 decades. It was developed in IIT Kharagpur by Dr. Sujoy K. Guha. So the mechanism of action being non-hormonal injectable contraceptive, it is composed of SMA, styrene malic anhydride mixed with DMSO, solvent dimethyl sulfoxide. It partially blocks the vas and destroys the sperm. So when this polymer is injected into the vas, it lines the it coats the wall of the vas deferens, and when this sperm passes through the vas deferens, it gets immobilized. So that is the action. So advantages, it is extremely effective, reversal proven in animals within 3 months, and side effects being transient, painless, self-limiting scrotal swelling, no granulomas like in vasectomy, or no effect on the prostate. This is something new, Smart RISUG. It's a new version which they actually added iron oxide and copper particles to the original compound SMA, giving it magnetic properties and the same, and thus the name Smart RISUG. So the difference is after injection into the vas, you can locate the polymer inside the vas deferens or you can visualize it by means of X-ray and MRI. So it can be externally controlled using a pulse magnetic field. So if you want to move it out of the vas, we can try for that. So that is why it is called as Smart RISUG. So concluding, family planning responsibility sharing by males can affirm our society a brighter future with better health of the weaker sectors of society, that is mother and child. Thank you.
Thank you, Dr. Aarti, for that extensive presentation on male contraception. What is the failure rate for the non-scalpel vasectomy?
It's less than 1%, ma'am.
Then why do you think it is acceptance is also in the same range, probably 1 to 2%? What is the major challenges for the acceptance of non-scalpel vasectomy?
One is, as I told ma'am, still the females are responsible in India, in scenario in India, still they think that females take the primary responsibility. So unless there is a medical or surgical indications, most of them are not accepting. But I think in the current era, recent studies are showing the men are also accepting the vasectomy, or they are scared, scared about the sterility. It's non-reversible also. Another one is non-reversible. It is irreversible.
Yeah.
Method.
So usually post vasectomy, how many ejaculations should we tell them to have before they achieve a complete sterility?
3 months, ma'am. It's 12 weeks.
12 weeks duration, but there is also a number of ejaculations that they should have. If it is going to be just 3 months of no ejaculation, then there is a possibility that the fertility might exceed the 3-month window also.
Not sure. Not the exact number. I'm not sure, ma'am.
Okay.
6 to 8.
What stage is the RISUG that you were talking about? Isn't it the one which was developed in IIT Kharagpur? What stage of the development is it at? Is it will it be ready for, or rather available for commercial use?
Currently, the trials are all over, ma'am. But I think it It is not yet into the market. So hoping, I think 2 to 3, within 1 or 2 years, it will come as what the latest.
As of now, it has completed its phase 3 clinical trials. It's finished its phase 3 clinical trials. So we might be expecting it to be launched in 2025 itself.
Yes, ma'am. Yes.
Yeah. Thank you, Dr. Aarti.
Thank you.
And I think to the audience as such, I think as gynecologists, we have to take the responsibility of motivating our, the husbands of our women and promote more of male sterilization as well. Thank you.
That's the reason this topic was chosen, Viji. Always we are talking about the female.
Email.
Yes.
Yes, Kirtana and Aarti did a wonderful work. Thank you, Dr. Viji.
Thank you, madam.
Yes.
Thank you, ma'am. The next session is about the MTP Act. I welcome Dr.
Shanti madam has
Sampath
some
ma'am.
urgency, so she is
Sampath ma'am.
apologist. You introduce Vivek Madi.
Okay. I welcome Dr. Vivek Madi, sir, who is a consultant and director of RK Malathi Hospital in Chennai. He is the faculty, Department of Education, International Chair in Bioethics, and steering committee member, Biolaw Department, International Chair in Bioethics. And we welcome him to give his talk on an interesting topic, MTP Act. Sampath ma'am will chair this session.
Welcome, Dr. Vivek Madi. You can tell what is the MTP Act, old, new, and what everyone, gynecologist should know.
Yeah, so thank you, Professor Sampath Kumari, and to the working committee members of the TNFOG for asking me to talk on this topic. I request the previous speaker to stop sharing her screen because I am not able to share my screen because her screen is still on. Is that all right?
Kirtana, have you stopped?
I'm unable to share my screen.
Dr.
Okay.
Kirtana?
Yeah, now it's okay. Yeah. Yeah, MTP Act, what's new? And that's what I'm going to talk to you about.
You can go for full screen.
Yeah, that's right. I'm going for full screen.
Yes.
I'm going to talk about the MTP Act 2021, the amendments. I think all of you are aware about our previous MTP Act of 1971. And when you see this, when a woman sees this double line in a pregnancy card, it sometimes gives pleasure to some people, happiness. Some others get despair, anguish, anxiety is there because it could be an unwanted pregnancy. And she comes to you to help her of this anxiety. So it is for us to make a decision on her termination and help her with her problem. And how this has come about is because termination of pregnancy is now legalized. Before 1971, and even now, actually, it is a crime. It is under IPC 3112, abortion is a criminal act. But then the parliamentarians have passed this MTP Act, an act to allow registered medical officers, practitioners, to do an abortion in a safe environment, and that has to be in a place which is registered with the authorities so that it is safe. It all started out in the USA, where it was first illegal. Abortion was legalized after this Roe and versus Wade case. They found that only by legalizing it, then you can bring down deaths from illegal abortions. And that's why after this case in USA, our MTP Act was passed in 1971, and it has made abortion very safe. So what is abortion? It is a termination of pregnancy by a surgical or a medical method. And it is done so that the pregnancy can be terminated, and it is an empowering act. The purpose of it is to help the women to make a choice on her reproductive rights and her decision to terminate. And it's for us to help her out. So anytime somebody comes for termination, it's not our duty to rub her off and send her off to somebody. It is for us to help. And that's why this MTP Act gives protection to doctors. Remember, this is an act to protect doctors from a criminal act. And what does it do? This latest MTP amendment helps us to terminate pregnancy up till 24 weeks. Okay. And if at all you need to terminate beyond 24 weeks, you need to get the permission of the medical board. So an MTP Act is to help doctors terminate pregnancy. Remember that. And it's all started in January 2020. It was passed through the Union Cabinet, the Lok Sabha, Rajya Sabha, and finally on March 25th, this act was passed by the Extraordinary Gazette. And it has 8 sections. And it's very important. What I want to tell you is this empowers us, registered medical practitioners, to terminate a pregnancy. And there's a section 4 which also says where it can be terminated. That means the place should be registered. It has to get approval from the district medical committee. The chief medical officer has to come and see the place. And if he is very satisfied that an abortion can be done in this safe environment, he gives you the license to terminate. So this is how it has come about, so that abortion is safe. We do not want our women to go to quacks or unregistered people and get into trouble and die. So we want certain care and safety factors to be involved in termination of pregnancy. The salient features. What's new in this? Earlier, in MTP Act 1971, you could terminate up to 20 weeks. Now, even now, this new amendment says that you can terminate up to 20 weeks without asking any questions. And this removes this marriage clause. So a woman doesn't need to be married. This helps all pregnant women up to 20 weeks to undergo termination. And it could be any reason. It could be failure of contraception or any method they have been using. So, of course, you don't need to question her for reasons for termination. Just make sure she's safe. She's not suffering from serious medical disorders or anything, so that you can terminate it with safety. 1. In case she comes late, it could be up to 24 weeks, you can terminate. And these women come under special categories. And later I'll tell you who are these women you can terminate. If they are beyond 20 weeks, up to 24 weeks, there is this clause. And the third point which this amendment brings out is the confidentiality clause, which has been introduced, where earlier it was only 1,000 rupees fine if you violate this. Now you can be imprisoned up to 1 year for violation. So this confidentiality is a very important clause which is mentioned in this amendment. And I will speak to you later on why this confidentiality clause has been introduced. And the fourth point which you have to remember is it gives you the power to terminate pregnancies beyond 24 weeks if the fetus is suffering from any substantial fetal anomalies. And for that, you need to get the members of the state medical board to tell it can be safely done. So that's the 4 salient features of this act. 1 is up to 20 weeks, no questions answered. Up to 24 weeks for certain categories. 3rd is the confidentiality clause. And 4th is approval of state medical board for any termination beyond 24 weeks in case the fetus is suffering from a substantial fetal anomaly. And whose opinion? You need 1 RMP if it's up to 20 weeks. Between 20 to 24 weeks, I told you the gray zone period, that you need to take 2 RMPs, registered medical practitioners, who will tell it is safe. And if you see a pregnant woman beyond 24 weeks, you have to take the approval from the state medical board, who will tell you that it is safe, that termination can be done safely. You have to give them all reasons how you're going to terminate it safely. We all know what are the two conditions for MTP, the same what it was in 1971 also. That is, any continuation of pregnancies which will involve a risk to the life of the pregnant woman or cause a grave injury to a physical or mental health. It could be due to a failure of contraception or due to pregnancy due to rape. Something which can cause a mental agony. If anybody says, I don't want to continue this pregnancy, it's giving me a lot of trouble and the mental thing, we need to agree to her choice, to her autonomy, and help her with this termination. Second is, if the child is suffering, if you feel, if the doctor feels the child could be born with a serious physical or mental abnormality, you can terminate. These are the two conditions for termination. Now, I'm going to tell you about the special condition of women who can be terminated between 20 to 24 weeks. They are the survivors of rape or incest. They could be minors for whom you have to take the opinion of a guardian, the consent from a guardian. Third is women with any physical disabilities or mental disability. Yes, she doesn't want to have a pregnancy. You can, even if she comes to you beyond 20 weeks, you can help her. And if there's a change in marital status, she was married, now suddenly she's got a divorce, and divorce has come to her at 22nd week, you can help her. And if by scan or any blood tests have shown that she could have a fetal malformation, you should help this woman. And like a woman in during a COVID period or a disaster, a war or anything, she comes to you for termination. Yes, and she's come to you at advanced stage between 20 to 24 weeks. You can terminate, but you must fill up this form E. What if she comes to you beyond 24 weeks? Then you have to go to a medical board. And for that, you have to fill up a form D, and medical board will have a gynecologist, pediatrician, a radiologist, and any other member as their choice. Could be a lawyer or a ethicist or anybody what the state medical state level board chooses. And once you get you give an application, within 72 hours, the state board will give their approval or rejection. And once they approve it, within 5 days of this approval, you must go ahead and terminate the pregnancy. In the letter, you have to show them, in the application, you have to give the reasons for termination and how you're going to terminate. And that's it. Now, this confidentiality clause, this is a very important clause, and this is the highlight of this MTP Act of 2021, because this gives you the confidentiality to women, to pregnant women, that she can terminate her pregnancy in privacy and confidentiality. What is confidentiality? It is a fundamental law. It is a fundamental law. It is a fundamental right of a woman to keep her confidentiality and her privacy and her decision to terminate with herself. You cannot even disclose this to anybody other than a person authorized by the law. It says that. And this confidential is so, it's because it is a fundamental right. A fundamental right cannot be abrogated even by any act. That's why even a POXO Act cannot overpower this confidentiality clause. When in confidentiality clause, it means that you need to keep the name of the patient confidential, and in your records, you can either put a pseudonym or a serial number, and it's your decision, it's your duty to keep the records safe, and it is not revealed to anybody about the termination of pregnancy. If a minor comes to you for termination, and if her guardian, she's along with a guardian, and the guardian says, I want this termination of this pregnancy for this minor to be kept confidential. I don't want anybody to know about it, including the police, if they say that, and you should get in writing from the patient saying that they want to keep this termination confidential, then the doctor is not liable for not disclosing this person's termination to the police. That means a doctor need not follow the POXO mandatory duty to inform the police because of this confidentiality clause. And this confidentiality clause is the fundamental right. Remember, fundamental right of anybody cannot be abrogated even by an act of the parliament. That is clearly come out. So therefore, this MTP Act of confidentiality is foremost, and it has been passed even in the Madras High Court, that a doctor need not inform the police on termination of pregnancy of a minor. So because of this confidentiality clause in this MTP Act. Now, I would like to just briefly tell you about how you terminate medical methods. It is allowed up till 9 weeks using mifepristone and misoprostol. You can terminate, but it is important you fill up Form C, consent form, Form 1, where is called the opinion form, Form 2, which is the register. Form 2 is the monthly statement, and Form 3 is the admission register form. So all these 3-4 forms have to be filled even for medical method of termination. And what about first trimester termination? In first place, has all you have to do is in the first trimester termination, you should have the backup facility to transfer the patient to a higher center in case of any complication. That backup, if you have, then you can get the approval. What about second trimester MTP? The important approval they look for is if you have a suitable operation theater with all instruments to do an emergency surgery. That's all they want to see. And you have these forms, all these forms, Form A for approval, Form B certificate. Form C is a very important, consent for MTP. Please don't do any MTP without consent. Most of the cases comes up because of not filling up this Form C and giving it to the authority. What about Form D? It is for those people beyond 24 weeks, how you have to report it to the medical board's decision has to be filled up in Form D. And for Form E is the opinion of 2 RFPs for termination of pregnancy between 20 to 24 weeks. That special category of people. Now, the last slide I come to is to tell you how this MTP Act 2021 is different from 1971 Act. This 2021 Act, here you have removed the marriage clause. The marriage clause is removed. Remember, you need not be married to come for termination. Even unmarried women can have termination of pregnancy. So you don't have to ask anybody, are you married? No. All you have to ask is, are you over 18 years? That's it. Okay. The gestational age, yes, this up to 24 weeks you can terminate. It is for all these rape survivors, incest, all the special category of people. Up to 24 weeks you can terminate. And if beyond 24 weeks, if you feel, yes, the fetus is substantial abnormalities, it will not survive even after birth, then you can terminate. After getting opinion from medical board. What about medical practitioners? All you need up to 20 weeks is the one single registered medical practitioner can give their opinion. Yes, this can be terminated. And if it's between 20 to 24 weeks, you need 2 doctors to say it is safe. And beyond 24 weeks, you get the approval of medical board. That's it. But the most important thing in this act, again, I'm telling you, is the confidentiality clause. Because in this confidential clause, you can be imprisoned and fined. And it is important for us that we maintain the confidentiality of the women, because that's what we want to give them the power. If you maintain confidentiality, you're giving power to women to take a decision on their reproductive choice or their reproductive rights. so that they can freely have freedom to make a choice of their reproductive career. So let us give them that power and not question them and make them feel uncomfortable. All we need to do is keep it confidential. They'll be happy. And the parliamentarians also want the same thing. They want us doctors to maintain confidentiality of our patients. So keep your records very safe. Keep it locked. Just the owner of the place need to keep the records safely. And you need not disclose even to the husband, not to anybody. It's a woman's right. This is a Women Empowerment Act. Thank you. Any questions? I'm ready to take.
Thank you, Dr. Vivek, for the wonderful presentation. Dr. Vivek, I have one question.
Yes.
You told now after 24 weeks, the state medical board.
Yes.
I heard that if at all it will take time, so you can have a medical board in your own institute. Is
Yes.
it like that?
Yes, you can have. If it is a government hospital, all you need to do is it has to be a government hospital, and they make a board having a gynecologist, sonologist, pediatrician, and even a woman. Any woman can be kept in as a part of the layman. Lay woman can be part of
Only
the
in
team.
government hospital or
It is better.
even in the
No.
private institute?
No, it can't be in a private institution because everything has to be in a government. The whole act has been passed by parliamentarians. So it is a government who can take decision, and they have trust only on government staff. At present, it is only government. No private institution can make, it's not yet approved for even societies to start their own medical board. It has to be a government.
See, now, for example, a patient is getting admitted in Apollo Hospital. If you ask the patient from the Apollo Hospital to go to Egmore Institute or RSRM,
yes,
she may not be willing to go, no?
No, it is only to get an approval. That's it. The determination can be done in Apollo, which is a registered center. Any registered center, you can get. But you're going to get an approval from a doctor who's authorized by the government. And their duty is to make sure it is safe. That's all. It's like a judge. That's it. The government doctors are kept in a high position as much as the judge to, instead of going to, earlier they had to go only to a court and get an approval. Now you don't need to get a court approval. You can make a board, but the medical board has to be a government.
Okay. Will the medical board be available every day, Vivek?
It has to be. Yes, I think
Madam,
it's a duty of a government hospitals to make a board. It is
sorry to interrupt, ma'am.
There should not be any delay while going.
I'm sorry to interrupt, ma'am. I'm Dr.
Yes,
Anita, ma'am.
Anita, tell.
We have a board, ma'am. It is when constituting a board itself, it is said that once they are registered, we give the report within 3 days, ma'am. There is no delay.
Yeah, that's what I said.
giving.
Within 3 days, it has to be given, and the termination has to be done within 5 days after getting the approval. So there's no delay. Once you get it,
The rule says it has to be given within 3 days. Once they appear for the board, they have to get the report within 3 days, whether they can do it or not.
Okay.
Ma'am, is it only, excuse me, is it only for anomalies or after 24 weeks?
Only for anomalies.
And the anomalies should
Lethal
not
anomalies.
be lethal. Yes, lethal.
That is why the board contains all the specialists, ma'am, cardiologists, neurologists, everyone. Whatever be the anomaly, they say this is lethal. The baby cannot survive. Then only we can terminate.
Vivek, I have one question for Vivek and Anita. See, now one of the patient in our hospital, now she has crossed, she came just now, that is, she is now 25 weeks. Her thyroid level is very high, 9 in spite of 200 microgram of thyroxine. If the baby may have some mentally retarded problem, no, if she is going to deliver, how to proceed with this patient?
Well, it says that if you are going to give a letter saying that it is for sure, it is going to be very lethal, then you can go ahead. You have to convince the authorities. You have to convince the medical board.
It will be
Yeah.
present even before 24 weeks, ma'am. We need not wait till 24 weeks for this.
Present,
they
but
are-
patient
they
has come
come.
now only.
Yeah, that's very
Patient has
sad.
come now only. We are controlling, but the thyroid is not getting controlled. Again, still now TSH is 9.4. Now we have taken the antibodies, but I want to know.
Yeah, but
Present
then
it in the
if it's
medical
not
board,
legal,
they have to accept.
yes.
Medical board has to give.
Medical board. That only I am asking, Vivek. The medical board
Yeah.
should be from the government hospital.
Yes, if they say yes, if they feel it is lethal, it's okay. Any condition. You have to
Okay.
prove,
But
prove your
without
point.
But without proof, like without a anomaly being manifested, we cannot give a report. No?
That only now this, if suppose if antibodies are positive means there is a possibility for MR, no?
See,
But
if,
the thalassemia we are doing, ma'am. Thalassemia, if the both are thalassemia
That
trait
is
and the
known
baby
fact.
happens
This
to be.
is, in my experience, this is the first case.
no, I'll tell you what. If, if the onus is on the medical board, if they say it is not lethal and further it becomes lethal, then they can be held responsible and it becomes a court case. So they will not want to take the risk. It'll be, I mean, it'll be easier for them to say it is lethal. And the main thing is it has to be safe. They want abortion to be safe. So we all know, even if it's beyond 24 weeks, we can conduct the abortion safely. It is not a problem at all.
So with the medical board, because
Medical board,
definitely
yes.
the baby will be going for MR.
Yes. So therefore, if when all that is there, they will approve. I don't think the medical board will.
Ma'am, they will not give approval for termination, ma'am. They will say it is a non-lethal abnormality, postnatal follow-up to be done for certain problems. Like that they will give.
What
Or
is the
they might
point
say-
of doing postnatal? Mentally retarded baby means
Yes.
what is the doing in follow-up?
See, we must see ethical point
Look
of
at
view. We
increase
must see
the dose of thyroxine.
Yeah, I agree
Increase
with you
the dose
because
of thyroxine. It's not a
200,
lethal
already
problem.
she is getting 200, madam. Anyway, I will tell you in later. Okay.
no, I think the medical board will be compassionate and they will say, okay, and there's no harm. All in all, the woman should not be harmed. You should do a safe
No,
abortion.
if at all the baby is going to deliver and the baby is going to be mentally retarded means then
Yes.
the patient will ask.
Yes, they will definitely feel very sad, and it's see the mentality of the parliament is to help women make a choice. That's it.
Yes.
So therefore, we are here to help them. We should not.
Anyway, thank you, Dr. Vivek Madi, for the wonderful. Any other questions? If no questions, we can go.
And one more question. Less than 16 years, girls coming with pregnancy, and so we are doing the MLC. We are filling the MLC form, sir.
Yes.
So on that, their name will be there.
Yes, but that's what I said. This clause, confidential clause, is a fundamental right now. So
how to avoid
if it is a fundamental right, we have to respect it. So even if she's 16 years below, and if a guardian, she can't give consent. Definitely, minors have. They don't have a right to give consent. If she's accompanied by a guardian, and if the guardian says, don't register, don't put her name anywhere, it doesn't become an MLC case. That's it. Over. It doesn't become an MLC case. You don't need to inform the police. It doesn't become a medical legal case. They don't take action. No, they will not, because you have the letter. If you don't have the letter, you're in trouble. You should get a letter from them saying that it's their request and you are following their order. Their fundamental right comes into place.
Okay.
So it's important you take the letter.
Written by them.
Yes, written by the guardian, not by the minor.
Okay.
Minor comes with a boyfriend. No, that will not help.
Okay.
There is another question from Susarita. Is there a mark of HbA1c beyond which we should advise MTP?
No, that is not.
No, not at all.
Not all.
You cannot fix a level of HbA1c as a criteria to proceed with MTP.
Yes. Okay. Thank you. Revati, madam. Thank you, Dr. Vivek.
Thank
Now
you,
we can
thank you,
introduce
Dr. Vivek.
Dr.
Madam,
Anjalakshi Madam. She has
one more
joined
doubt,
our.
sir. Excuse me, sir. Dr.
Yes, yes.
Sir, am I audible?
Yes.
In spite of the board decision, some parents request MTP, even if they have some anomaly. The parents are not willing to continue the pregnancy. How can we deal with such situation, though the board does not agree?
No, beyond 24 weeks, if it is not lethal, you cannot do anything about it. They
We
have
cannot
to
do
continue.
anything,
Yes,
even if the parents ask.
yes, because the right of the fetus comes into place. The parents lose their power. They have the only power only up to 24 weeks. There
Okay,
is
sir.
beyond 24 weeks, viability period comes in, and the baby is supposed to be got the rights to live, and government protect the rights.
Okay,
That's the
sir.
point. So
Okay, sir.
it becomes a citizen automatically beyond 24 weeks.
And
Okay,
the dad dies during the
Thank you, sir.
pregnancy.
Ah,
The dad dies during the pregnancy. She's married
That-
only for 8 months and
Ah.
she's pregnant 7 months. And the dad died of suicide.
so she becomes a widow. So she's below 24 weeks, it's okay. Not beyond 24 weeks.
Beyond.
After 24 weeks, she becomes a widow, you can terminate. Even 23rd week, she becomes a widow, you can terminate.
But not beyond 24.
Not 24 weeks.
Okay.
The son will be the support, Radhika.
A daughter also.
Daughter also.
Yes,
Yeah. That's
maybe.
what we call.
Okay. Yes,
Okay.
You
thank
can
you,
move
Dr.
on to the
Vivek.
next session.
Yes, ma'am.
Before that, we can introduce our guest of
Fine.
honor, Dr.
Yes,
Anjalakshi Madam.
She has
Yes, sir.
joined. Okay.
She has joined.
Welcome, madam.
Welcome.
Chitrakala, can we have the CV of Dr. Anjalakshi Madam?
Yes, ma'am.
Madam, இருக்கீங்களா Anjalakshi Madam?
காணுமே அவங்கள.
சரி, அப்ப பேனல் இன்ட்ரோடியூஸ் பண்ணி இப்ப அவங்க வாய்ஸ் கேட்டுச்சு. ஓகே. Okay, Chitrakala. Dr. Radhika, you continue with the panel.
Yes, ma'am.
Thank you, Dr. Vivek.
Thank you.
Thank you, sir. That was a very informative session. The next is the panel discussion.
Good afternoon, madam.
Radhika, can you introduce
ma'am.
Dr. Karpagam and the panelist?
Sure, ma'am. Okay. Good evening, Dr. S. Karpagam, ma'am.
Yes.
She is an undergraduate of Stanley Medical College and postgraduate at Stanley Medical College again. And she's done her MD at the Institute of OBG Egmore, attached to Madras Medical College in 2004. And she's an associate professor in KAPV Medical College, Trichy, from 2020. Welcome, ma'am. And I welcome Dr. Saravana Kumar, who has done his undergraduation from WIMS Bellary, MD from Madras Medical College. He is the professor and HOD of Annapurna Medical College, also consultant in Malar Maternity Hospital, Salem. He has initiated and trained young doctors in operative laparoscopy in Annapurna Medical College. Welcome, sir. Dr. B. Vijaya, madam. She has done her MBBS from Madurai Medical College and Madras post-graduation in Madras Medical College in 2005. And she's done a DPNB from OB 2010. And she's published many case studies in international journals. Now she's an associate professor of Dindigul Medical College. Welcome, ma'am. Dr. Anita Tamreshalvi, ma'am. She's a professor of OBG, Government Dharmapuri Medical College Hospital, and also secretary of OG Society in Krishnagiri. Her areas of interest are high-risk obstetrics and social obstetrics. Welcome, ma'am.
Thank you.
And I welcome Dr. S. Gayatri, who's MS OBG and also fellow in reproductive medicine, medical director of Hari Infertility Center, Tirunelveli Foxy secretary. She's a secretary in Tirunelveli Foxy, and she's delivered the first IVF baby of Tirunelveli, winner of the prestigious John Isaacs competition in active management of labor, and participated as a faculty in many state and national conferences. Welcome, Dr. Gayatri. And Dr. Prema Priya, who is Associate Professor, Vinayaka Mission, Kribananda Warrior Medical College, Salem, Tamil Nadu. She's done her fellowship training in endogynecology at GEM Hospital, Coimbatore. She has numerous publications and presentation. Her area of interest are adolescent gynecology, high-risk pregnancy. She has won the Best Poster Yuva Foxy South Zone Award in Madurai 2016. Welcome, ma'am.
Thank you, ma'am.
Welcome, ma'am. I also welcome Dr. Gomati, madam, who is a consultant obstetrician gynecologist, Government Stanley Medical College, visiting consultant in Bivel, Sudarshan, and KC hospitals. And she's won Esther Gold Medal Award in contraception. Special skills are high-risk pregnancy, infertility, laparoscopy, colposcopy, and sonology. I welcome Dr.
Thank you, ma'am.
Welcome, ma'am. And Dr. Jaya Meena, ma'am, who is has done her MBBS from Meenakshi Medical College and MS from ESI PG MSR ESI Medical College, Joka and Kolkata. Passed Depend B exams in the year 2021. Welcome all of you for the panel discussion. And let's start.
Meena is assistant in Muthukumaran Medical College. You didn't tell that.
Yes, ma'am. Currently working as assistant professor in Sri Muthukumaran Medical College, Chennai.
Yes, thank you, Radhika. Thank you.
Sorry.
Karpagam stage is yours.
Yes, madam. Shall I start?
Yes, ma'am.
Yes, Karpagam.
Good afternoon, everyone. So my topic is moderation for the panel discussion on contraception in special conditions. So my first question is the contraception for an adolescent girl of 17 years who comes with 40 days amenorrhea for MTP. She wants to complete her education and also request ongoing contraception after the MTP.
You can mention the names, Karpagam, because it is a webinar. No, they may not be knowing.
Oh.
No, you can mention whom you are asking the questions. You call by name.
Okay.
One by one.
Because they may not be able. If it is a physical means, it's okay.
Okay, madam. So, Vijaya, madam.
Good evening, ma'am.
Good evening.
Can I audible, ma'am?
Yeah, yes. Yes, you are audible, madam.
Thank you for the opportunity, ma'am. Thank you, one and all. For in this case, it is 17 years old girl with 40 days amenorrhea. First of all, we have to ask the history, detailed history of the person. 40 days amenorrhea, we have to ask the whether she's, even though she's married or unmarried, we have to provide the contraception method and MTPs. Even though we have to ask the history and we have to examine the patient and we have to do the basic investigations.
Yes, madam.
And all the history, we have to ask whether she is taking any drugs, any anti-epileptics or any TB drugs she is taking. And the history we have to ask. In investigation, we have to first we have to look if she is anemic or not. And after all this, we can advise her for the medical termination of pregnancy by MMA method. That is MIFI-MISO method.
Yes,
talk to her.
But since she is less than 18 years, she belongs to a POXO case, no, ma'am. We should.
17 years. That only I asked whether she is married or unmarried. Even if it is POXO case also, but according to the surveys, we have to be careful about the medico-legal aspect of this case.
Yes, madam.
We have to screen her for sexually transmitted infections, STIs also, ma'am, since she's an adolescent.
Okay, madam. So even whether she is married or unmarried, of course, we can, after confirming whether she's pregnant or not, whether it is, of course, with ultrasound, whether intrauterine, extrauterine, we can give the MMA kit, isn't it, madam?
Yes, ma'am.
Yes, ma'am. But if she gives a case and she wants the products of conception to prove the person who is at fault, we have to do a
So
curettage.
in medico-legal, if she comes
Medical legal, if she is
as a
not
case of
sure of
rape,
who has done that
yes, madam.
act, then we have to go for a
Oh, yes.
curettage and then.
But this is suppose this woman, this is a sexually active girl who just requires a MTP. She doesn't
Then
want to go.
MMA,
Then because
medical
now
method.
a lot of college students are coming for MMA kit nowadays. So now we have to also, our the flow of thought, we have to change according to the present generation, isn't it, madam? Yes, madam.
Ma'am, less than 18, excuse me, ma'am, less than 18 years, the forensic department is asking for the stored DNA.
Yes, madam.
So it's better to.
Yes, madam. Correct, madam. But is this 17? If it is a 17-year-old girl, as you say, it is a medical legal, even if she gives consent. So in that case, as you say, madam, we have to send the products of conception to the forensic.
We have to store the products only if the person is not known. If parental dispute is there, if the person himself accepts, we can go with MMA. It is safer for the patient.
Yes, madam. What ongoing contraception can be advised for these girls to protect themselves, adolescent girls? Madam, Gomati, madam.
Yes, ma'am. Actually, since she is an adolescent young girl who is unmarried, actually
Yes,
it's better to give her sex education, like awareness of fertile period and health, societal norms and everything. And if at all she persists that she wants an contraceptive methods, the first choice of she is according to the WHO medically eligibility criteria, she will be coming under grade category 1 only. So we
Yes,
can offer her contraceptive pills, but contraceptive pills for a long run, it is not good for taking regularly, the compliance and everything. Again, she might come with a backup failure. So especially as I feel that she should be advised sex education. Second thing, injectable contraceptives can be given, ma'am. So
Yes,
the advantages and disadvantages should be told to them.
Sir?
Ma'am,
Madam?
ma'am, can you hear me, ma'am?
Yes, ma'am.
And
Yes, ma'am, you're audible.
The first choice she can go for barrier always, because it will protect against sexually transmitted diseases also.
Can I interrupt? If am I allowed to interrupt? And
Sir, yes, sir.
sir.
Please, sir.
yes, can I just say a few things about medical legal aspects? See, if she's a minor, less than 18 years, so actually in this case, she's a 17-year-old girl.
Yes.
Clearly, POSCO Act comes into place. POSCO Act says that
Yes,
it's our duty to inform the police. It becomes an MLC case, and if she's going to ask for contraceptive advice, that means she wants to continue have a sexual activity. That is not allowed. Minors are not allowed to cannot be allowed to have sexual activity. So therefore, as a doctor, we can give advice. We can have sex education advice we can give, but we cannot prescribe contraception. So we cannot put an implant in a minor. That's all I want to say.
Yes.
We cannot put an implant or any contraception cannot be given to any minor. In fact, I had a patient from one doctor from down south had asked me, because her case was filed against her in the court because she gave advice on contraception to an adolescent girl. So
Yes,
that's
sir.
what I'm trying to say. If she's an adolescent, we are not allowed to give advice. I mean, I'm not allowed to give contraceptive method, but we can give sexual education advice.
Sexual education.
Yes, advice, but not
Sir, but
contraceptive.
but in our area, we get many people who are married and 17 years, and
Yes.
they are studying also. They want to delay the pregnancy.
Yes.
Then we have to give them contraceptive advice.
Yes,
Married
yes,
with their parental consent.
Yes, that's what I'm saying. No, only if with consent of a guardian you can give.
Oh, yes,
If
sir.
the guardian comes and says, if a husband is the guardian and he comes and says, my wife needs contraceptive care, you're supposed to give contraceptive care. But if she's
Yes,
an
sir.
unmarried girl,
Yes.
school student, please don't give any contraceptive pill. That's all I'm saying. If she's a school girl, she's come alone with a boyfriend or even a girlfriend or anybody, and she's without a 18-year-old adult with her, you cannot give her, because you are allowing her to have sexual activity, and you can be penalized for that. That means you are part of encouraging her sexual activity, and you will be penalized. You will have the same penal action.
Yes, sir. But lot of in our place, lot of child marriage less than 18 years.
That's
we
what
are
I'm saying. No,
encountering.
no,
That
that's
is why
okay. That's what
we
it
have
is.
this doubt.
There, guardian comes. Again, I'm saying, if a guardian comes, if a major, more adult, if an adult comes and tells, please give, then we can give. If the adult says, I want her to have contraceptive advice, okay. But otherwise, yes, less than 18 years, they come under minor POXO Act. POXO is very, very clear. They want to stop any sexual activity below 18 years. That's all. And it is gender neutral. Girl or boy, less than 18 years, no sexual activity, no harassment, anything.
Okay, sir. Thank you, sir. It was very enlightening, sir.
Sorry for interruption, because people were deviating. That's why I had to.
Yes, sir. Sure, sir. But this is the problem, no? During the COVID period, lot of minors and married minors were coming to the hospital. So we had this problem.
Yeah, but if a guardian is there, no problem. Somebody, an adult is there with them, no problem.
Yes, sir. But even in those cases, we had MLC entered and we went through the proper way in the hospital. But these girls, yes, sir. All these girls, no, they are not sent back home, sir. They are all sent back to the, to the welfare center. So that is also, they are not allowed to go with their parents.
No, now it's changed. That's why there is a new, the High Court, Madras High Court has passed a law saying that if a guardian is taking responsibility, no problem. That is the husband. Husband has to be more than 18 years. If less than 18 years, marriage is not even allowed. Only if she comes from certain caste, it's allowed. I don't want to mention the minority caste.
Yes, sir. Yes, sir.
I think.
So on this, I had a dilemma whether to say married or unmarried. So since sir said, I think we all of us have got a clarity regarding this. Sir, Sarana Kumar sir, anything to say, sir?
Yeah, actually, what I wanted to tell is these sort of girls are very commonly seen in our practice. The only thing is, though we see them alone, at times we ask them to bring their parents or someone else so that we can give them direct advice to them. Not that we are admonishing these girls. Only thing we want to have some parental support for them, because we don't know whether it's a consensual sex or it is regularly happening with some elders, maybe in the family or outside. So that sort of shouldn't be happening for these girls. And the other thing is we have to give some sexual advice for these girls, whether contraceptive or not. We have to tell them that they have to have condoms so that prevents other type of sexually transmitted disease also.
Yes, sir. Sir, shall we go to the next scenario, sir?
Yes.
Shall I go on? Yes, sir.
Yeah, we can go on to this.
So I will go on, sir. Since all these methods Sarah has told, I'll go to the second case. So Mrs. X, para 1 live 1, delivered 3 months back, has approached the postnatal OP for an effective contraceptive method to space the next pregnancy. IUCD was not kept for her as she had a PPH during the delivery. So Anita madam, what would be the ideal contraceptive for this lactating female?
Ma'am, we want to have a long-term contraception at least for 2 years or 3 years. For a good spacing. So it is better to go for a copper T, ma'am, long-term method. And if she is not willing for copper T, we have to go for a injection also, DMPA. since she's breastfeeding, she cannot have OC pills, but she can have progesterone only. So you can go for a DMPA injection, and ormeloxifene can also be allowed in a lactating women. Newer method,
yes,
I mean, newer contraception that is available even in the government setup. So best will be cooperative for her, since she needs for a long-term period spacing. Then the second will be DMPA injection, which can be given after 6 weeks. And third would be ormeloxifene.
Yes, madam. So progesterone only pill. Can combined oral contraceptive pills be given, madam?
Since she's breastfeeding, the quality of the breast milk is affected by the estrogen part of it, so we have to avoid.
Yes, madam. So combined OC pills cannot be given because it affects the quality of milk. Any other methods that can be advised, madam? I think you have already told, madam. And of course, madam has also told about our Chaya. And Antara.
Antara injection.
Antara injection and Chaya injection can also be started after 6 weeks, madam.
Yes, ma'am.
Yes. So the government is providing all this, and in this Antara is very much accepted by the public, sir. Women are happy regarding this Antara injection because it is more friendly for them compared to the IUCD. There's a lot of positive response to Antara, sir. Vivek, sir.
What I saw in my practice in Karnataka as well as in Tamil Nadu is,
yes, sir.
5 years in Karnataka, people are more accepted for IUCD there. And here they don't want an IUCD at all, at any cost, how much ever.
In Tamil Nadu, sir, we have a lot of difficulty in convincing them for IUCD.
So
yes, sir.
Just the injection that
they don't mind injections. Yes, sir.
Injections that is predominant practice for me now for this postnatal mother after 3 months. And they say that they can give post-delivery also, DMPA.
Yes, sir.
Yes, sir. After 6 weeks, sir.
Yes.
6 weeks
yes,
after
sir.
delivery, 42 days.
Yes, sir. Especially PPIUCD, we all have a difficulty in convincing, sir. Somehow
it is very difficult. Government, I don't know, but majority of the
patients somehow
in the government, they have PPIUCD. But here it is very difficult to convince the patient for a PPIUCD.
In the private sector, yes, sir. In government, somehow we achieve, but in private sector, it's a little difficult. So the third case scenario, 35 years, Mrs. X, para 2 live 2. She has rheumatic heart disease with mild pulmonary hypertension. She is not sterilized, has had an unprotected sexual intercourse, has presented to the postnatal clinic for advice and management. Excuse me, madam. Madam Prema Priya, madam.
Yes, ma'am. Ma'am, since she has already 2 live children with rheumatic heart disease with pulmonary hypertension, first of all, since she had an UPC, that is unprotected sexual intercourse, I'd like to give an emergency contraceptive pills. But at the same time, I would like to advise her for permanent methods of sterilization, such as tubectomy or vasectomy, ma'am. Since she has rheumatic heart disease with pulmonary hypertension and completed family also.
Yes.
I'd go for that, ma'am.
Okay. Can emergency contraception, is there any contraindication in this situation, madam?
Levonorgestrel pills can be given even in case of heart disease, ma'am.
Yes. So it is not contraindicated in any medical condition for that matter. Yes, madam. Any other method of ongoing contraception, madam?
Ma'am, as I mentioned, I would like to go for a permanent method, ma'am. Suppose if she's not willing for permanent methods, then IUCDs can be given for her, ma'am.
Yes, madam. So barrier IUCD provided there is no risk for infective endocarditis. So she should not be having any pelvic.
We should also advise for vasectomy, ma'am.
Yes, ma'am.
Vasectomy for the husband. She's para 2 live 2 and pulmonary hypertension. So we will convince her husband for vasectomy.
Yes, madam. A very difficult task, but we will definitely do, madam.
Yes, ma'am.
Sir, Aruna Kumar, sir. Okay. Shall I go on with the next, madam, or anything more about special conditions? Shall I go to the next scenario, madam?
Yes, ma'am.
Dr. Gayatri, madam. This question, 24 years, para 1 live 1, LCB 1 year back, history of preeclampsia in the pregnancy, wants a long-term temporary method of contraception. Her BP now is 160/100. What long-term method of contraception can be given to this mother? She's hypertensive, madam. So she's on ongoing hypertension. In spite of that, she has not reverted to normal her BP, madam. Madam, are you available? Audible, madam? Okay. Or anyone among the panelists?
Ma'am, she
Yes,
is
madam.
24 years only. She
Yes,
is
madam.
a case of chronic hypertension, pre-eclampsia with superimposed chronic hypertension. Now also her BP is high. So her BMI
Yes,
will
madam.
be definitely, we have to consider her BMI and health issues.
Yes, sir.
So the long-term contraception, the copper T will be ideal, ma'am. So WHO MEC criteria, she will be eligible for the copper T, ma'am. But other
Yes,
methods will be, there will be IUCDs. Other methods, she might have some disadvantages as well as
yes,
breakthrough
madam.
bleeding or any other complications. So it's better for her. The first choice will be IUCD.
IUCD. Yes, madam.
Either LNG or copper T.
Yes, madam. So the ideal long-term temporary method will be, of course, IUCD. Can we in preeclampsia, madam, regarding injectable contraceptives?
Ma'am, she since 24 years with chronic hypertension, she might have other comorbid factors also, ma'am. So injectable
Yes,
again can be given. It comes under category 2. The advantages will definitely outweigh the risk, but still the best will be the copper T. If she is not motivated for copper T, she can go for injectables, provided we can give her advice of breakthrough bleeding if we counsel them better. So giving the disadvantages of injectables like breakthrough bleeding, secondary epidurals, and sometimes the people can get an accidental pregnancy. So she will be motivated for IUCDs.
Yes, madam. Thank you, madam.
Ma'am, this
Thank you.
progesterone only pill cannot be used for a long-term method, ma'am.
Yes, ma'am. Okay.
It cannot be used because the time we have to take the
That has to be the time.
very difficult to follow.
Yes, madam. Thank you, madam.
DMPA injections can be given, ma'am.
DMPA, madam.
Can be given, yes.
Yes.
DMPA can be given. LNG IUCD is okay, but PUP oral pills is not ideal for a long-term method.
Yes, madam.
PUP is only for lactating women. Immediately, if we want, we can use PUP, but for any long-term method, PUP cannot be
Long-term
used.
method. Above all, of course. Yes, madam. All. But as madam says, the topmost list is, of course, our IUC.
Advise her to finish the family as soon as possible, because she's a chronic hypertensive. As the age progresses, again she will fall under the other category of having more comorbidities. So anything is okay, IUCD or a DMPA, 2 years, and then she can plan for her next pregnancy.
She can end with one is enough.
Yes, but nobody listens now. Everybody wants to have one more child, madam.
But she has to decide, ma'am.
So she has to decide, and they are willing to take risk in spite of various medical conditions to have one more child, though we keep saying. So definitely we have to find some method to protect her. Yes, sir.
And after 1 year, if she is having at 24 years this much of BP, there should be some cause for it, which may worsen when if she becomes again pregnant with superadded preeclampsia and eclampsia.
That's
so it's better to come.
Yeah.
Yes, sir. Of course, we should advise, but then most of them never take our advice. No, sir. They come back again after 1 year with another pregnancy. Even though their previous pregnancy is a life and death support, they don't mind. They are more brave than us. We are the people having heart attacks. Yes. Shall I go to the next scenario, sir?
Yes.
Okay, madam. Okay. Just a minute. So to Dr. Jayamina madam, 24 years, para 1 live 1, LCB 1 year back with history of preeclampsia in the pregnancy. Oh, I think I repeated the same thing. Sorry. 35 years, Mrs. X, rheumatic heart disease. Oh, I think I've completed the case scenario. Sorry, sir. Yes, one more scenario. To Jaimina madam, 25 years, Mrs. X, previous full-term normal delivery 6 months back, wants advice for contraception for breastfeeding, birth spacing. She is on anti-epileptics. What method of contraception can be used for patients on convulsions?
Ma'am, since she's on, ma'am, am I audible?
Yes, you're audible. Yes, you're audible, madam.
Hello. Yeah, ma'am, since she's on, yes, ma'am, since she's on anti-epileptics, I would suggest IUCD, ma'am, because anti-epileptics are enzyme inducers, and giving her combined oral contraceptives or progesterone only pills will have no effect. So IUCD would be a better choice for her. And along with that, barrier method can also be suggested, ma'am.
Yes, ma'am. So barrier methods and IUCD. Can hormonal contraceptive pills be used in these women, madam?
Ma'am, since hormonal contraceptives and anti-epileptics have similar enzyme actions, they induce each other's enzymes, ma'am. So the metabolism is faster, and hence hormonal contraceptive won't be effective in these cases, ma'am.
Yes, ma'am. Thank you. So the last case scenario to Gayatri. I think I've asked Gayatri. Prema Priya, madam, have I asked? Have I missed anyone? Gomati, madam.
Yes,
25 years back. Yes, Gomati, madam. Mrs. X, 25 years back. Yes. Am I audible?
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
25 years, para 6 live 1. She's a case of APLA positive patient. LCB 6 weeks back has come to the postnatal OP for temporary contraception. APLA positive patient. What contraception of choice for this patient, madam?
Since she is a case of APLA positive, we have to get a detailed history because she has previous 6 abortions or miscarriages. So that history is very important to know the details. Ideally, she becomes for she is according to WHO medical eligibility criteria, the combined contraceptive pills cannot be given. She is category 4 for that, but she can be given barrier methods as well as IUCDs.
Yes, madam.
Progesterone pills also can be given, ma'am. Since
Can
she's
we
6
give,
weeks.
Can be given because progesterone also. See, ma'am, progesterone also for a long term, considering her to take for a long term, it is not suitable. So that's what I thought, because even that can cause she can have a DVTs or any thrombophilia factors positive. So that history we have to elicit, and we have to screen her for thrombophilia factors also.
Yes.
So having APLA.
Best choice could be IUCD and barriers.
Of course. Can we use Sunproman, madam?
Yes, ma'am. Yes, ma'am, we can use. We have to avoid estrogen part only, ma'am. She's more prone for clotting, VTE.
She can be given
put on progesterone alone, injections also, and ormiloxifene can also be safely used.
Yes,
excepting estrogen part, and also the newer progesterone, which are prone for causing clot, the VTE, more chances of VTE, we have to avoid.
Yes,
we can give DMT also, ormiloxifene also, ma'am.
Okay, madam. So anyway, as madam said, barrier method and IUCD still will be the best for these patients, because we are also seeing this group of patients also with the connective tissue disorders. Yes, madam. Saravana Kumar sir. I finished the case scenario. Anything more?
Yes, madam. I think it covers everything which we see commonly in our practice. And,
I hope I have covered the various aspects. Finally, I think the IUCD comes the best, I mean, the topper in all the contraceptive methods so far discussed, safer methods. So barrier and the IUCD still are the, I mean, more popular among all the other methods.
Yeah, it's better to have this WHO wheel in our practice, so that we have like how they give this LMPEDD wheel. If they give one of the WHO wheels, we'll be able to at least properly counsel our patients regarding what we can give for this patient.
Yes, sir.
As a university.
So, yes, sir. Actually, contraceptive method with the pregnancy antenatal during our antenatal visits itself, we should discuss about this with the mothers so that they will be prepared for this spacing also. Yes, madam. Madam Sampath Kumari, madam.
Yeah, yes, madam. Wonderful. Each panelist one case scenario. Well discussed.
Yes,
and the panelist also. Yes,
yes,
you have
madam.
covered everything. Really wonderful.
Yes.
Thank you.
Especially that 17 years was a very good topic, man. Sir also gave us such a lot of clarity in the 17-year-old child, which we all of us have the doubt.
Well done, Karpagam and panelist. Very clear and nice cases. Thank you.
Thank you.
Thank you very much.
Thank you,
ma'am.
all the panelists and expert advisor. Thank you, madam. Revati, madam.
Thank you, madam.
Thank you.
Thank you, ma'am. Thank you. Thank you, ma'am.
Vijaya, thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you.
Radhika, Anjalakshmi madam illana vote of thanks. Karpagam, can you stop sharing?
Sampath, I'm there. But the video is not working in the cell phone. Okay, I was listening. I was listening to the panel and Dr. Vivek Madi's half of the talk. My best wishes, of course, after the good end of the program, I am telling the best wishes. Any of this, the contraception was the least discussed topic, actually. The last year and all, we did not discuss. So it is a new topic and we have lot of gray areas. I think Dr. Vivek has clarified some of the problems with the MTPs. So anyhow, my best wishes, and I congratulate Dr. Revati and Dr. Sampath Kumari for this wonderful topic and the discussion. And let TNFOG, what to say, have its good goal. So whatever goal we have set in, let us achieve those goals. And my best wishes. Thank you. Thank you.
Thank you, madam. Thank you so much.
Thank you, ma'am.
Thank you. Bye. Radhika, what of thanks?
Okay, ma'am. Thank you, ma'am. Thank you, Anjalakshmi, ma'am. I thank Dr. Sunita Tandulkar, ma'am, who is the president-elect Foxy and who graced the occasion today. And thank you, Revati, ma'am, for your presence and guidance, ma'am. And thank you, Sampath, ma'am, the main organizer, Dr. Vijayalakshmi Yanasegaran, ma'am, and
Lakshmi Kandasamy.
Yes, ma'am. Then the Yuva Foxy session judges, Dr. Vijayalakshmi Kandasamy, ma'am, thank you so much for being there and enlightening with the points, and the speakers, Dr. Kirtana and Dr. Aarti, who have done a great job. And I thank the Madam Sampath, ma'am, for chairing the scientific session. Thank you, Vivek, sir, for the excellent input regarding the MTP Act and clearing our doubts. And I thank Dr. Karpagam, ma'am, and Dr. Saravana Kumar, sir, who has done a wonderful job as moderator and experts in the panel discussion. And thank Vijaya, madam, Anita, madam, Dr. Prema, ma'am, Gomati, ma'am, Dr. Jayamina, then Dr. Gayatri. That was a wonderful panel discussion, and I hope all the delegates and all of us have been enlightened regarding the knowledge about contraception. And Thank you everyone for attending this session. And every month we are doing this session on the second Friday, and we welcome your presence during the next session. Thank you one and all. And thank you Chitrakala.
Radhika, and
Thank
thanks
you.
Chitrakala and
Thank
Shield
you so
for
much,
their
madam,
academic
for
partners.
giving.
Thank you.
Thank you.
And
for
Sri
giving.
Priya, our event.
Yes, ma'am.